Good morning and welcome, everyone. Thank you so much for joining us today. We'll let folks get settled in and we will be starting momentarily. Good morning and welcome. Thank you again for joining us for our Black History Month panel presentation featuring 2024 Hall of Fame recipients of the Museum of African American Addictions, Treatment, and Recovery. Today's webinar is brought to you by the Great Lakes ATTC and SAMHSA. The Great Lakes ATTC, MHTTC, and PTTC are funded by SAMHSA under the following cooperative agreements. The views expressed in this webinar are the views of the speakers and do not reflect the official position of DHHS or SAMHSA. The ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. We do have a few housekeeping items for you. If you have any technical issues, please individually message me, Alyssa Kuala, or Jen Winslow in the chat section, and we would be happy to assist you. If you have any questions for the panelists, please put them in the Q&A section of your toolbar, and we will be taking some time towards the end to answer your questions. If captions or live transcript would be helpful, please locate that option using your Zoom toolbar to enable them. At the end of today's presentation, we will have a short post-event survey for you all to please fill out. It should only take 2 to 3 minutes. Certificates of attendance will be sent out via email to all who attended this session in full, and the recording will be available on the Great Lakes ATTC website following today's session. If you would like to stay connected with the Great Lakes ATTC, follow us on our Facebook page. We also have LinkedIn, YouTube, and our Spotify channel. And I'm super honored to hand this over to Mark and Kisha to share a little bit more about our panelists.
Good morning, everyone. I had a little snafu there with my mute button. Thank you so much for joining us today. We're really excited about speaking with our panelists today. They are outstanding professionals, and I'll go ahead and introduce each one of them to you. First, we have Dr. Corey Vilsant. She is the Associate Director of Recovery Health Equity at the Recovery Research Institute and an instructor at Harvard Medical School. Second, we have Dr. Fred Dyer. He is a practitioner, presenter, consultant, and writer specializing in providing culturally responsive treatment for African American adolescents, emerging adults, and emerging adult refugees. And then we have Dr. Sherelle Bellamy, professor at Yale University's Department of Psychiatry and community-based behavioral health researcher working with communities of color. Representative LaShawn Ford. Congressman Ford is the representative of the 8th District of Illinois. And finally, Dr. Felicia Pullen, qualitative researcher exploring structural racism's impact on attaining recovery capital for people of color with histories of drug use. So if you'd like to click on the reactions button to give an applause to our panelists today, go ahead and do so. We're really excited about engaging with them. And just also want to mention before I turn it over to Mark so we can get started, you do have the Q&A section on your Zoom bar. If you want to ask questions, you can type those questions in the chat, or I'm sorry, in the Q&A, and then we'll answer your questions at the end. And if you just like to engage with one another in the chat, or give a thumbs up like you're doing right now, feel free to do so. And over to you, Mark.
Thank you so much, Kisha, and good morning, everyone. I'd like to start by giving a shout out and a thank you to Jen and Alyssa for hosting our webinar today. They host hundreds of webinars per year, so thank you so very much. I'd like to thank Kisha for co-moderating the panel with me and the 5 Hall of Fame recipients, right? Thank you so very much for all that you've accomplished and for being with us today and the wisdom that you'd like to impart, that you will impart. I thank you in advance for that. And then for those of you joining us, so webinars often begin with the polling of an audience. So by show of hands, to all the participants, raise your hand if you do outstanding work. We want to see, Kisha, how many people with us are really good at their job. Let's see those hands. We see some thumbs going up. Okay, very good. How many of you feel, as a result of the work that you do, that you're making a difference in the lives of at least one human being, at least one person benefits from your work? And how many of you feel, as a result of the work that you do, that you deserve a $90,000 a year pay increase? Every hand goes up twice. Know that I know that the world cannot compensate you enough for the work that you do. Keisha asked me if I had a joke this morning. I don't have a joke, but I have a story for you. In honor of that work, then we'll get into asking the panelists questions. In 1983, here's the story. I had a job where I earned lots of money, $13,000 a year. I decided to go back to school so I could learn more, but also so I could make more money. So in order to do that, I took an evening job. I went from earning $13,000 a year to $10,000 a year. I don't know if you know what a $10,000 a year paycheck looks like. It's about $300 every 2 weeks. And I was given $150 of those dollars to the school I attended, Loyola University of Chicago, and $125 every 2 weeks to my roommate, leaving me $25 every 2 weeks for ramen noodles. So as a social work student, I did an internship. My internship was at a hospital. And the first day I showed up, I was asked to go home because I was wearing gym shoes. They said, this is the professional hospital. We don't wear gym shoes here. So where was I going to get a pair of dress shoes for $25? You're thinking Salvation Army, Goodwill. Years ago, there was a discount shoe chain called Favor Shoes. Walked into Favor Shoes, and the only shoes I could afford for $25 were plastic. And it was September, and as you know, it rains a lot in September. So I quickly discovered that plastic and rain, they don't mix. I was slipping and sliding all over the place. And right around November, I had a larger concern. A hole formed right at the tip of my shoe. So now I'm walking and my shoes are talking. You ever had a hole in your shoe? December, I'm frightened. Because it snows a lot in Chicago in December. My fear was that snow would get in the tip of my shoe and I'd die of frostbite. So I took my shoe to the nearest shoe shop. The owner looked at my shoe and he frowned and said, you may as well throw these away, pal. These are plastic. We don't fix plastic. It's not worth it. He said, plastic can't be fixed. Putting my head down, I walked a mile, stumbled into another shoe shop, sat the shoe on the counter. The owner looked at my shoe and he's frowned. He said, throw these away, pal. These are plastic. We don't fix plastic. Plastic can't be fixed. And I'm desperate. I walked 2 miles, stumbled into another shoe shop. Sat the shoe on the counter. He looked at my shoe for what felt like a lifetime. My heart was beating so fast. And he was going to say, we don't fix plastic. Plastic can't be fixed. He said nothing, reached back, picked up a magnifying glass, looked at my shoe and he smiled. He said, I'll fix it. That was 1983. This is year 2024. He's been fixing my shoes for 41 years. Not the same pair. But he fixed those 5 times that year. What he said to me is it takes a special person to work at fixing something. And the rest of the world says it's not worth it, they can't be fixed. And that's the same thing a lot of people say about the clients you serve. It's not worth it. It can't be fixed. Thank you so very much for dedicating your life to this work. Know that I know again, the world cannot compensate you enough for that work. Let's begin with our questions to the Hall of Famers. Much has changed in the substance use disorders profession over the course of the last 20 years. We want to find out from you one thing you think we're getting right as a profession, and then one thing that you think that we're struggling to get right. This is the thing that makes you stay up at night, want to pull your own hair out. What are we getting right and where are we struggling? In no certain order. Who'd like to respond?
I'm happy to start. All right. Well, I would say that one thing that's going well is that the science on long-term recovery has grown. We now know it takes about 15 years before a person's quality of life returns to the same level as those without a substance use disorder. Additionally, we understand it takes about 5 years of continuous sobriety before the risk of a recurrence drops below 15% in the following year, which is when you're no more likely than somebody in the general population to have a substance use disorder. But this is too long. Now, I want you to imagine if we could accelerate that to a fraction of the time, let's say 5 years instead of 15 to return to quality of life. That's what we're doing in the investigation of recovery support services like recovery community centers, recovery housing, collegiate recovery programs, digital recovery support services. We're moving from an acute care paradigm of detox, medical stabilization, brief episodic treatment, and 12-week clinical trials to an emerging third tier on a continuing care paradigm. We are building and testing the efficacy of a more diversified infrastructure that may attract and engage some of the 80 to 90% of people who do not receive treatment for their substance use disorders. Now, what keeps me up at night is that the likelihood is not the same for everybody. In fact, we know from national studies that Black individuals are half as likely to achieve remission as their white counterparts. This has been exacerbated by a lack of racial literacy in the medical and scientific field, where Black patients are more likely to be viewed as drug-seeking. And a two-tiered treatment system has emerged where life-saving medications for opioid use disorder are now prescribed at half the rate to Black patients, despite having the same number of medical visits as their white counterparts. And then a recent study of perinatal opioid use disorder found that when Black newborns manifest withdrawal symptoms similar to their white counterparts, they receive less pharmacological treatment. And what is worse is that the scientists explain these differences in terms of biological differences without even mention to the possibility of institutional racism. That is a practice of pseudoscience left over from a long history of scientific racism that still lingers in healthcare. And that is what keeps me up at night.
Well, that was super fantastic, Doctor. And I concur with her perspective. I would say thank you for having me. What we have right now is, I think that we're now beginning to see this as a collective problem. We're collaborating more, and the stigma is becoming less about the need to provide people that are struggling with substance use disorder the care that they need. That's something that I think we have going better than we did in the past. And what keeps me up at night now is the constant flow of fentanyl into this country, and especially in neighborhoods like Austin and in Black neighborhoods where it's even more difficult to overcome the life challenges. These fentanyl drugs are coming in faster than it's ever come in before. They're coming in pills. And now we know that young people are also being victims of this fentanyl drug that's coming into our country. Thank you.
Hi, everybody. Felicia, and I just want to say what we have gotten right is that we've really given the mic to people of color who are doing the work. I think that it's really important that we encourage people of color to continue to do the work, to talk with and about people of color. I think that one of the other things that we've gotten right is an expansion of some definitions, right, of recovery specifically. Historically, recovery meant abstinence, and I think that the broadening of that definition is something that we have gotten right, that allows people to self-define, self-determine what recovery means to them. And I'll use that to give a shout out to Dr. Villasant, who has done so much work in the Recovery Capital framework. I think that it's really important that we are now using scales and frames and Recovery Capital assessment tools to understand what recovery can mean to so many people. What keeps me up at night is the racial disparities in deaths. That keeps me up at night. I am deeply disturbed that of the 3,026 overdose deaths in New York City, over 2,000 of them, or 68% of them, were people of color. That keeps me up at night. What keeps me up at night is that we're not talking about some of the other substances that are involved in the overdose deaths. And so this is not an opioid epidemic. It is a fentanyl issue. And what we need to understand is that cocaine was involved in 50% of the overdose deaths in New York City. And we need to talk about that if we're going to continue to address cultural and racial disparities. And so I'm going to pass that mic over to whomever else wants to take it next, but certainly a lot of sleepless nights out here.
Thank you, Dr. Felicia. I think we are so much in alignment here. I would say what I think is working well is all of us here, right? Seeing so many Black faces in leadership. I'm thankful to see that Michael Askew is now in a leadership role at SAMHSA, that Dr. Miriam Delphin-Rittman is in a leadership role, the top leadership role at SAMHSA. I'm happy to see that all of us are leaders, but we need so much more, because what we're not seeing is that when people walk into these agencies or organizations, they're not seeing people that look like them in most cities. So we need more people of color who are working in this area, and particularly in leadership roles. What continues to keep me up at night, very similarly, is that we are dying disproportionately in terms of overdose rates. What keeps me up at night is that my 31-year-old cousin Jasmine died 2 years ago right here in Connecticut, and I couldn't even find her to offer her the intervention that I work on. So what keeps me up at night is that, you know, we have only touched the surface. There's so much more that we need to do.
Dr. Dyer, you're still on mute. Yes, we can hear you.
You can hear me? What's
Yes.
going well? Well, I want to say thank you to the committee members who voted me in and who asked me to be a part of this, and to Dr. Sanders for this opportunity. What's going well? Adolescence has always been there. I had a conversation some time ago with the late Dr. Carl Bell. And Dr. Bell, I asked Dr. Bell a question one time, and I would go up and see him, and I would go up to Dr. Bell's office for 12 years straight. Every January, I'd go up and see him over on 87th and Constance, there in Chicago. And I asked Dr. Bell about writers and individuals who in substance abuse and mental health who don't address, or who won't address for whatever reason, who won't address African Americans. And this would even include emerging adults. Dr. Bell, in his soft-spoken way, looked at me and he said, he kind of shrugged his shoulders, and he said, well, you know, it's okay, because they can't make any money talking about us. The challenge is talking about us, meaning African-American adolescents at that time. Dr. Bell said, the key is, and the challenge is to make sure that you and I don't forget to talk about our kids and to work with our kids. So what's going well right now is that in the literature, there seems to be an avalanche of material relegated to emerging adults and to African-American adolescents. What keeps me up at night is that, and I've discovered this, and I'm calling from Minneapolis, Minnesota, is that there are agencies, and I'm not being critical, I'm just making a statement. Agencies that I've have had contact with, apparently for whatever reason, don't get it. You can't take interventions and strategies and programming that was designed for white males and white women, and see and make it and translate that over to African-American emerging adults or persons of color, or you know, it just doesn't work. So that's what keeps me up at night, because I've seen it, I've observed it, But you know, we stay on the case and we still persevere.
Thank you so very much for those responses. And one of the things I was thinking about is that we have people who are tuned into the webinar today who are specialists. They are passionate about serving various populations. There's some with us today who are passionate about serving individuals with disabilities, Latino Hispanic communities, LGBTQIA communities, women, individuals who are incarcerated, gang affiliated clients. And sometimes because of their interest, their passion, they get pushback. They hear things like, oh, the addiction, mental illness are equal opportunity employers. They affect us all the same. Whether you're a butcher, baker, or a candlestick maker, doesn't matter. They get pushback. Matter of fact, I'm reflecting on when my dad died smoking crack. May 29, 1986. I wrote a book in his honor on counseling African American males. And my colleagues said, why would you do that? Where are you going to work? So what we want to ask you, panelists, Hall of Famers, is you have these specializations as it pertains to working with African Americans. We want to know your why, perhaps your personal why, or your professional why. What keeps you hanging in there with this specialization? Thank you, Brianne.
Hi, I love that question because this is something that I actually pose to young people, right, who are interested in the field, whatever field it is. I ask them to ask themselves, what are your who, what, where, when, and why? And when you can do that and do that in a way that's intentional, work doesn't feel like work. And so for me, work does not feel like work. My who is Black people all day long. I am a Black woman. I am an unapologetically Black woman, and I am here for my Black people. My what is addiction, recovery, harm reduction, treatment, because I am a woman in recovery. And for me, that means that I am no longer drinking, no longer consuming substances, but I did so for a very long time in the community of Harlem, in the community of the Bronx, and wherever else I could possibly be that would allow me to be in an environment where I could consume. And so I am driven by prevention of the onset of use for Black teens and Black youth, because if I can help or support a young person, and so thank you so much, Dr. Dyer, for your focus on young people, right? Because it's the ACEs that cause people to use. So if I could disrupt in some way, shape, or form a young person from using, and going down the road of chaotic use that I traveled, that is my what. But for those who do travel down that road, how can I support their recovery however they define it? And so that is my why. I am here for that all day long. I eat, sleep, and breathe it. And so my why is that my Black people deserve recovery, however they define recovery to be. And so however I can support them in getting there, that's my why.
Okay, I'll go. So the second question is good. The why. As a state representative working in the community on the west side of Chicago for the last 17 years, we have what you call the heroin highway. We have more deaths from heroin overdoses on the west side of Chicago than many places in the country. And that has impacted my life, my family, over and over and over again. Some of my very special people in my family have died from a preventable drug overdose. And so I think that that's why I have a strong passion for continuing this work of harm reduction for Black people in Illinois, because what I know is a fatal overdose is preventable. people do not have to die from a drug overdose if they're treated fairly and in non-biased ways. You know, I look at my colleagues across the state of Illinois. It's 118 of us, and the state is very diverse. And when you look at the care that people receive in certain parts of the state compared to the care that people are receiving on the west side of Chicago or the south side of Chicago, it speaks to why life expectancy is less for Black people, because the care isn't adequate. And so I think that when we look at the possibilities of implementing harm reduction, I think that we can definitely prevent unwanted deaths. It's very, very hard for a person living in a Black community to recover. A person goes to recovery and come home to the community where the drugs are being sold, and it's easier to buy heroin from the neighborhood that you live in and trying to recover. Whereas you have a person living in the suburbs, a more affluent community, it's easier to recover because you don't walk out of your door to the sale of heroin in your neighborhood. You have to travel to get it. And guess where they travel? To my neighborhood. So I want to make sure that we do everything to have the best harm reductions in Illinois as possible.
Thank you very much for that, Representative. I would say for myself, what motivated me early on was realizing that the preconceived ideas that were planted in the media and stereotypes about Black people and substance use were later challenged upon researching the facts. I grew up in the 80s when Black people were prevented from being on MTV until Prince and Michael Jackson broke the color barrier, yet Black people using drugs were easily and prominently featured on televised anti-drug campaigns. But the facts are that Black youth have a later age of first initiation and experimentation with various types of substances by about 2 years compared to their white counterparts. The truth is that there is a culture of resistance to drugs and alcohol in the Black community. And this is even reflected in the age of onset for a substance use disorder, which occurs in the late teens on average for everybody, with the exception of Black communities where onset occurs in the early 20s. In fact, I think there is a part of the reason that we study various communities is to learn what is working there and if it can be replicated to other communities. There is a strength-based story happening there that is not being told in the Black community. Nonetheless, the stunning paradox of inequity is that we've got 30 to 40 years of research showing that prior to the age of 35, Black Americans are suffering a disproportionate burden of substance-related health and social consequences compared to their counterparts, despite significantly lower and sometimes equivalent levels of substance use and substance use disorders. This unjustifiable truth is what motivates my research. And to that end, I'll take a second to thank the Recovery Research Institute, where I currently study, as well as my graduate school advisor, Melvin Wilson, who have constantly offered their resources to support African-American recovery. Thank you.
I am Black, I am woman, I am queer, I am Gullah Geechee, I am mad, I am a survivor. I am from Trenton, New Jersey, by way of South Carolina. And Dr. Corey, I did not actually start using until much later. Once I went to graduate school, actually, to deal with the trauma that I was facing from having been abused as a child. And I wanted to just say that for so many of us, we need that support. We need to know that there are people out there who are able to talk about, their experiences with their lived experience. I also just want to say what motivates me is that we continue to die, 25 years earlier than the rest of the population. And that's Black people, that's people with histories of mental illness, that's people with histories of substance use. And it's criminal. It's criminal to keep saying it and do nothing about it and to just watch it. We need to make sure that there are resources and financial resources put into this space to make sure that we are doing something to decrease that.
Thank you for your responses. And Representative Ford, when Dr. Bellamy was speaking, I was thinking about Dr. Jennifer Smith at Cook County Hospital on the west side of Chicago. Dr. Smith believed, because of what Dr. Bellamy just mentioned, that life expectancy is shorter because of like chronic stress and racism for African Americans, even in recovery. So she started a movement where she wanted everybody in the neighborhood that was seeking recovery to have a primary care physician, not to treat them for their substance use disorder, but to monitor them for medical complications, medical conditions, which they may not even know that they have, connected to their addiction, even in recovery. Thank you all for that. I turn everything over to Kisha at this time.
Outstanding. I want to start off with our first question for Dr. Vilsaint. Based on your research, if clinicians could help build recovery capital, how would that impact outcomes for African Americans with substance use disorders?
Great. Well, thank you. Thank you for the question. And I'm actually delighted to say as well, I'll speak for a little bit, but I consider Dr. Poland to be a guiding light in this area as well. So I'm so excited to hear from her. The first thing I would say about recovery capital, recovery capital first help the field by changing the narrative on what meaningful improvements look like beyond deficiencies, pathologies, and substance use alone. Recovery is more than the absence of disease. It is about the presence of health. In fact, there was a review of the literature that found the strongest predictor of remission was strength-based assessments and resources, which is essentially recovery capital. Capital is the building materials by which we can reconstruct the lives when examined as part of other recovery vital signs. It can reveal much knowledge about the course of recovery, including nature, degree, timing of critical changes that can help providers identify recovery milestones, turning points that reflects vulnerability, resilience, or growth. But ultimately, this in turn can inform more central questions about which we can build an effective public health infrastructure to address substance use disorders. These questions are who needs what type of service, when in their recovery, for what duration, and what intensity. So, for example, we now know that those with opioid or stimulant use disorders begin their recovery journeys at a substantial disadvantage in terms of recovery capital relative to those resolving alcohol or cannabis problems. And it takes several years for them to achieve similar rates. This means that those who use methamphetamine, crack, cocaine, heroin, fentanyl may be amongst the most marginalized and stigmatized. As such, they have a distinct disadvantage early in the recovery process in terms of access to recovery resources, and attention may need to be paid to these individuals in particular. They may require more resources and immediate access to what I call rebuilding permits and architectural planning to reconstruct this person's life compared to other primary drug groups. Now, in terms of clinical or peer providers, one levels of recovery capital can play a role in treatment or recovery planning when it's considered alongside their problem severity. In fact, recovery capital has been adopted by the American Society of Addiction Medicine for use in their placement criteria. So just an example, if you have a person who arrives at treatment in response to a positive drug screen, maybe they have a moderate problem severity, high recovery capital, screening and brief intervention might be quite appropriate. Sometimes these individuals may terminate problematic substance use around their first attempt. But on the other hand, if you have a client that comes in with high severity, high complexity, extremely low recovery capital, they may be placed in high intensity services, longer durations that have a broader scope and can even be graduated into step down services. Now, In terms of benefits for African Americans, you have to understand that recovery capital is a protective factor. Right? African American women in particular have been shown to have the most barriers to recovery in some studies. And so recovery capital can influence resiliency, coping. It can help mitigate and counteract barriers and the high burden that is associated with biological and psychological stressors associated with adaptation to abstinence and remission from substance use disorders. Thank you for the question.
Thank
Keisha,
you.
Dr. Dye is not with us right now, so you can pose the next.
Okay, and this next question is for Dr. Bellamy. One of your many roles is director of the Imani Breakthrough Opioid Recovery Project, which serves African Americans and Hispanic Latinos communities through a faith-based initiative. What are the benefits of integrating spirituality, recovery support, and partnering with faith-based initiatives?
Thank you so much for that question. First of all, I just want to give a shout out to the Imani team, to my colleague, Dr. Ayana Jordan, who's at NYU, who also is in the Hall of Fame. So I'm proud to be here to follow her. I also just wanted to give a shout out to the rest of the Imani team, many of them who are online today watching this. And thank you for always supporting the work that we do in the community. Imani, first of all, was developed by the community, for the community, and primarily with the church itself and with people with lived experience. I also just wanted to say that Imani means faith in Swahili, for those that don't know that. And part of that faith, in a very simplified but real way, is just even having someone to be able to hold on to believing in you, even when you can't believe in yourself. And I know that that was really important in my recovery, having someone able to hold on to that belief for me when I wasn't able to tap into it. And now I can tap into it, and it's really important to be able to spread that joy to other people. I also just wanted to say that, first of all, we also know that for many Black and Latina individuals, that spirituality and religion is something that we grew up with. The stats suggest that 65 to 85% of people of color attend church regularly. And I often say, even for those that don't attend church regularly, you might have a mama like mine somewhere who's on her knees praying for me right now. And that's just really important, because we do turn to spirituality to help soothe, to help cope. Many of us may not have started to use drugs to cope. Many were just trying out to see, because it felt good. But at some point, it did become a way to cope. It did become a way to self-soothe. And I'm talking about my own personal experiences here with crack cocaine and with other drugs. I think it's really important that we're able to, name it and call it what it is, instead of being shameful of talking about our drug use experiences. I also just wanted to say that Imani initially, really involved two facilitators, a facilitator that was in the church, a church member, and a facilitator that was a person with lived experience. What we've seen over time is that those lines have blurred. There's no longer that division, that people, those church members, are now coming out and talking about their lived experience. Once we get more people talking about their lived experience, then we're going to be able to really see a change in how we're viewing drug use in the church. The other thing that's awesome about Imani is that Imani is for people who are currently using drugs. That means that people are walking into the church that are currently using drugs. We are not hiding the fact that people are using drugs. We need to stop hiding it, because that's leading to more secrecy, and that's leading to more deaths. People should not be using drugs alone. People should not need to go into these hotel rooms and be by themselves and lonely in this process. There's so much out there for people today. So yes, we have a lot to do in terms of, really dealing with the church around drug use. We've come really far, but yes, the church still discriminates. There are some churches that still discriminate. And a lot of that is really, again, because people are not talking honestly about their own lived experiences and letting people know that there's drug use happening right there in the pulpit. So thank you.
So Keisha, I have a follow-up question for Dr. Bellamy. Because as you were speaking, I was thinking about the 1980s when it looked like crack cocaine was going to take over the world. The prison population tripled, right? And treatment disappeared. And every denomination of African American church formed their own drug-based ministries. It was like people in recovery said to their pastors, we need to treat our own. And they were everywhere. I would go to these large revivals in Black communities for recovery. I even heard Vanity sing and tell her recovery story. She left the road with Prince and got into long-term recovery, became an evangelist for recovery. But what split that movement up were denominational differences. And if ever there was a time when we needed the church to be involved again, we'll be in the midst of this opioid, and as Rep. Ford said, fentanyl crisis. So if you ruled the world, how would you work with church communities so that things like denominational differences wouldn't get in the way of the ability to work together to help promote recovery ongoing?
Yeah, I mean, that would be certainly the key. One thing I will say is that we do work across denominations. We work with churches that are Pentecostal, as well as churches that are Baptist, across the board. So I think that it's really important that the church leaders themselves are the ones that do this, that they also are able to accept anyone that's coming into their church. And I think part of that religious dogma, then gets in there too, because then it's about who can come in, who's the sinner, who's the saved. And that's where we really do need to make sure we're addressing those issues. But if we don't get church leaders that are standing up and saying, enough of this, let's come together and address this issue. Because if the church is really into the business of saving lives, they better make sure that they have lives in the chairs of the church in order to save, because otherwise we're losing too many people, not only to overdose, but as folks have already talked about, also to other, health concerns. Again, we're dying, 25 years earlier across the board, and we have to make sure that church leaders who have that, advantage of just being in front of lots of people every Sunday and throughout the week are able to give out that message of hope.
Thank you so much for your response to that. Okay, Representative Ford, in March of last year, you shared concerns about the effects of Medicaid redetermination on individuals and families affected by opioid use disorders on the west side of Chicago. In what ways does Medicaid redetermination contribute to healthcare disparities, and what are some of the first steps we can take to close the gap?
Yeah, thank you, Kisha, for that. And thank you, Mark, and all of the people here today. So I would say congratulations to all the new Hall of Famers and all of the harm reduction workers across the country. It seems as though you gathered, and I didn't know that we're going to have people from across the country. So congratulations on that. And for all the future Hall of Famers that's in the making. I'm sure there are a lot right now that's doing the work that will one day be a Hall of Famer. And I would say, I'm going to get to the redetermination. I'm going to stick to the 5 minutes, but it's so very important to know that recovery works. Because look at what we have. We've heard personal testimonies here today that we're given a God gift of the ability to move into recovery, maybe having the love of family members, having health insurance in order to help them recover. So we know recovery works. We have 2 panelists here that spoke about recovery, PhD. So congratulations to you two. And all those that's in recovery for surviving and being people with lived experience, helping lead people to recovery. One of the greatest gifts that we have that President Obama fought for was Affordable Care Act. That Affordable Care Act was a landmark piece of legislation that the current president called a big effing deal. And it is, because poor people right now could be covered by health insurance. Medicaid is health insurance. And I think that everyone should know that it is a good form of health insurance. And one of the problems that we have in the nation is redetermination. So Medicaid redetermination is a problem and can indeed contribute to healthcare disparities, which is why I raised the concern about people losing it. In several ways, it could impact us. First, the redetermination process can lead to a disruption in healthcare coverage for the vulnerable population, including those with opioid use disorder in recovery. These individuals rely on Medicaid for essential services like addiction treatment, counseling, and medical assistant treatment and recovery. Any gaps in coverage due to redetermination process can interrupt the continuity of care, leading to increased health risk and further cause the disparities to grow. Secondly, the redetermination process may disproportionately affect lower income communities, and especially Black people who may face barriers in navigating the complex paperwork that's required to be redetermined. This can result in higher rates of disqualification and loss of coverage among disadvantaged communities and individuals, widening the gap in healthcare access and outcomes. To address these disparities and close the gaps, several steps that we could take, I'll speak to next. But if we think about the pandemic, how people lost the continuity of care because hospitals and providers closed their doors, we saw a real increase in overdose deaths and overdose. That's why it's important that people maintain their health coverage as a individual. I think Mark came off mute, so I'll stop the.
No, keep.
Okay. And so I would say some steps that we can take is increase outreach and education, implementing and targeted outreach programs to ensure individuals and families in affected communities are well informed about Medicaid redetermination process, providing resource and guidance and assistance to help them navigate the paperwork and requirements, reducing the risk of disqualification. We need to continue to advocate for a simpler process for redetermination, and we need to do everything we can for continuing of care plans, increase funding for addiction treatment, and collaborations and data sharing to foster the collaboration between healthcare providers and social work agencies. This will help with the loss of lives and increased life expectancy. I would say that Illinois, it was reported by the feds that Illinois was one of the 2 states that actually scored very high as it related to redetermination. We had a 90% redetermination rate, but that still is not good, because we know that there's 10% out there that did not get redetermined and lost their health insurance, on top of those that never had health insurance. So health insurance saved lives, and redetermination is a process that we really, really have to fix in this country. It's impacting every state that opted into Obamacare.
Thank you so much, Rep. Ford. I have a follow-up question for you. One of my professors used to say, there are too many therapists sitting behind desks while people are dying outside. And historian William White said, if we wait for clients to hit rock bottom and crawl into our facilities to get help, many can outwait us, especially some of the individuals who live on the west side of the city of Chicago. And H. Wesley Clark said that they're not going to come in. We've got to go out and get them. That's on the west side. You're doing all this community outreach. But here's the question. It's so impressive. I'm going to whisper the question for dramatic effect. How have you been able to get 33 organizations, right, to go on the west side of Chicago on foot all season and provide community outreach? Rush Hospital is there outside providing services, harm reduction services. How have you been able to do that?
You know, I think that it is the support that we have for the West Side Heroin Opioid Task Force is amazing. So what we've been able to do is collaborate with the providers. We have a major problem in Chicago, South and West Sides, of people dying. And it happened because we have providers, social workers and healthcare providers and advocates that believe that there is a possibility to save lives. And just having the great leadership of the West Side Heroin Opioid Task Force convening people with the support of the DHS and HFS in the state of Illinois, we've been able to convene meetings and go out with providers across the west side of Chicago to link them to care and to pass out what is it called? To pass out the help me, Mark, the reversal.
Yeah, you all are distributing Narcan, bringing people back to life.
I've never been at a loss for words. Narcan is in my
Bringing
mind.
people back to life.
Everybody has Narcan. So we have distributed Narcan across the west side. We have the boxes, purple boxes, the newspaper stands with Narcan in it, and people respectfully remove their Narcan kits, and they're saving lives. We have vending machines that has come from the West Side Heroin Task Force meetings to say that we need to make sure that we have Narcan available every term where it's needed. So it's really just been me having the ability to work with people and real leaders in the state wanting to do it. And so I think it's something that everyone could do no matter where you're at. Convene the meetings and people will come because everyone has had someone in their life that has been impacted by or been impacted by this problem of heroin in our country and in the world.
Thank you so very much. And Dr. Pullum, I never got a chance to share this, but I admire the fact that as a researcher, just like Dr. Vilsan, you're like boots on the ground. So you connect with average everyday people, and it's a beautiful thing for us to witness and be a part of, right? Lots of people with us today are boots on the ground. So here's the question. Based upon your research on structural racism and how it impacts the ability of African Americans and other people of color to attain recovery capital, what are your recommendations as to how clinicians and programs can use your research findings to improve outcomes for clients they serve?
Yeah, when I got that question, I was like, oh, this is a really big question. And so I often encourage people to look beyond the individual that they're serving. I don't promote social determinants of health. I truly believe in political determinants of health. And so what that means is that there are systems in play that impact people negatively, right? So we didn't really touch on the negative side of the recovery capital scale. And I think that we need to do that. So if we're really truly asking providers, practitioners to support individuals, I think we need to also ask them to dismantle some of the systems that the people are living and working within, right? So what we do see is that there is an intersection of race, poverty, geography, and substance use, and that is not by happenstance. And so what we're seeing, not only in New York, but around the country, is that people who are living in concentrated poverty are at greater risk of overdose deaths than people that are living in more wealthy parts of the city, right? So that means that 4 communities in the Bronx, East Harlem, Central Harlem are the top 5, 6 communities in New York City with the highest rates of overdose deaths. So that's the geography piece. The racial piece is that Black men between the ages of 55 and 84 are dying at the highest rates of increase in the greatest numbers. Black people in general and Latinx people are dying at the greatest rates of increase, right? So that's the race piece. And so we have the intersection of the poverty, the race, and the geography that I think needs to be dismantled. The only way that we can do that is if we take a look at the systems in which people are living, not just at the individual themselves. So what do we do about concentrated poverty? We invest in housing, affordable housing. We invest in educational systems that can help lift people up out of generational poverty. We invest in employment and job placement and workforce development. We invest in parenting skills enhancement. We invest in holistic approaches to help people with their human capital, right? So I love the work that has been, the groundwork that has been laid before me, because I didn't have to create this wheel. All I had to do was take a look at it and to really understand how we can use it to add some pieces to it. So the political capital piece is the piece that I've added to this recovery capital scale to put the ownership of what we are seeing on the ground on the political systems that are directly responsible for them. When we start to look at the carceral state, we understand that the political determinants of health were directly responsible for the mass incarceration of people of color. And so how do we begin to Representative Ford's point, help individuals who are living in concentrated poverty, who are not being reinstated in Medicaid and Medicare systems, still access recovery capital. And so I think that there are things that we can do to support the practitioners that are beginning to do this work alongside all of those that are on this panel. I absolutely love what Dr. Bellamy was talking about, right? The institution of religion is a way that we can begin to help people with influence in Black communities to support people of color who are still using substances. So that's an institutional piece that we need to look at. And so one of the final things I want to say is that we need to understand that there are cultural nuances to working with people of color. Practitioners need to understand and work on their, for lack of a better word, their understanding of people of color in order to support people of color, specifically Black people. How do we understand that historical trauma has been passed down through generations? And so research shows that, right? So when do you begin to increase your cultural capital to be able to work specifically with people of color to enhance their attainment of recovery capital? So one, practitioners need to enhance their understanding of cultural responsiveness. We need to dismantle systems that are perpetuating trauma, that are perpetuating poverty, that are perpetuating low rates of educational attainment, that are perpetuating wealth and health gaps. So those are pieces that we need to work on. I think, and finally, in terms of the structural racism piece, we need to have practitioners working on the policy part. Stop the hyper focus on the individuals and begin to look at policy, because it's the policy pieces that are perpetuating the issues. And so I'm a policy person, and my focus is I'm in DC, I'm in Albany, I'm talking to OMH, I'm talking to Oasis, because unless we attack those systems, we're only going to be on this part of let me help you individual or individually, instead of more of a mass approach to supporting people of color.
Mark, I don't know if you have a follow-up question, but I do just want to share that you all are really inspiring our audience today. I'm looking at the chat. People are, awed by the idea of, I'm trying to remember what you said, the political, instead of social determinants of health, the political.
Sure.
They're inspired with Representative Ford's task force work, and people are wanting to organize and do the same, and they're inspired by Imani, and each one of you, you all are just really blowing this out of the water today, and it's exciting to see people wanting to take action and to make change because of the work that you all are doing, and I just want you to know that.
And Keisha, once we attended a conference, it was in Canada, a research conference. And I had a chance to say a few words, and I suggested that we leave the conference and go over to the reservation. Find out how this First Nation tribe in British Columbia, Canada, went from 100% alcohol use disorder to 95% recovery. How they maintained that over a 40-year period, right? So that what triggered that memory was that Fania Buford Berry, who works with Representative Ford on the west side of the city of Chicago, she invites all of us that are with us today to get on a plane, a bus, or a train and go to the west side of the city of Chicago and watch what they're doing in the street, right? Because they're saving lives. As I said, they have over 30 partners out there helping to save lives. Someone said to me that if you save one life, it's like you saved all of humanity. So we're ready, Keisha.
Well, this question is for each of you, and feel free to jump in and answer, for whoever's the most ready. How can individuals and programs increase their cultural responsiveness when serving African Americans with substance use disorders?
I would go with Dr. Paul. She was right. This is all about public policy, and that we have to make sure that we don't have bad public policy that hinders individuals from serving in communities, policies that don't direct funding to communities that need it, policies that's not socially competent and biased. So it all deals with having good public policy. Public policy should not be leading to more deaths. It should prevent it. And we know that some of the policies that we have in Illinois actually are bad and standing in the way of saving lives. I mean, we know there are some proven harm reduction tools out that we can actually use to save lives. And I have to say, the one is an overdose prevention site. And we know that it will save lives. We know it will lead people to recovery, but yet we have public policies that stand in the way.
Read, read, read. Ask yourself your questions of what are your racial attitudes? Is there implicit bias? Are you carrying stigmatizing narratives in your mind that has been passed down generationally to you? Understand that not all people are treated or equally in our two-payer healthcare system, right? There are books like Uche Blackstock's Legacy that talks about the impact of these racial health and wealth gaps that people are experiencing every day. So it's not a mystery. We're not keeping this information secret so that only we can talk about it on panels. There are plenty of resources out there that can help individuals understand and increase their cultural responsiveness, cultural capital, cultural understanding, and so that they can improve and enhance their work with people of color. So Google, read, ask, email.
Can you repeat the title of the book that you mentioned, Dr. Pullen, for our audience?
Legacy by Uche Blackstock.
Well, yeah, I'm a big fan of what Dr. Pullen and the representative are expressing. These are structural issues. These are about the macro level of things, not the microaggressions in large that are driving these disparities that we have by far. NIH has come out and put that out there. That's why so many of our interventions have limited effects over time, is because we are working on changing cognitive biases, thoughts and behaviors, but the root cause is at the organizational, the policy, and the structural level. Those are mechanisms of health disparities right there. Those are your actionable targets. And the good news is when you target those, not only will you reduce health disparities, you will improve quality of life for everybody usually. They're bad for everybody and twice as bad for people of color. That's what I see in my science. So, I'll go ahead and give a response in terms of cultural responsiveness, African Americans, and I will only second it to what Poland said. I love the structural piece. If you want to know what's been found in the clinical setting, this is outside of SUD settings, but it has been documented, so you can get this from the National Academy of Sciences. What's been going on in clinical encounters? We know 7 touch points where implicit bias is coming through in the healthcare setting with patients of color. 1, limited time given by clinicians to patients of color. We also see 2, that there's inequity in how the time is spent with patients of color. There's inequity in the conversational pace and tone. There is dismissive clinician body language that is going on with Black patients. We've captured the data, we've got it. We've got inequity in information sharing. We've also coded inequity in resource use and inequity in shared decision making. Those are the touch points of implicit bias that have come out of the clinical encounters literature. If you want to talk a little bit here about more of in the treatment realm, substance use disorders, if you're thinking about opioid use disorders, we are aware medications are considered a frontline treatment. And sure, you can explain to your patients the benefits of that recovery pathway option in terms of decreased craving, relieving withdrawal symptoms, returning to the workforce. These are all evidence-based things that are coming from these medications. But at the same time, we also know from studies at the Recovery Research Institute, African Americans are more likely to have negative views towards medications. So what else are you going to offer them? This is when we got to get in there. We got to look at efficacy at other pathways to recovery. Be prepared to let them know about recovery housing. For example, this has shown considerable benefits for opioid use disorder in strong clinical trials, meaning you explain to people their options after detoxification. When patients were given a list of services and they decided on their own, their pathway to recovery, only 13% were abstinent at 6 months. But after detox, if they went to recovery housing, you've got 37% abstinence from opioids and cocaine at 6 months. And when you combine that housing with some reinforcement-based treatment, the number goes up to 50%. Let's give people options so they can choose their pathways to recovery, and understanding that most people are not going to want the medications. There is a narrative out there right now that abstinence-based pathways kill, but I will tell you there is a limit on the science right now that is being tested. Recovery housing has not been tested up against medications, and we need to do that so we can articulate the pathways to the people that are going to help them. And so I'll stop there. Thank you.
Thank you. I just want to say amen, 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 right? So you all have said it. And shout out to Dr. Uche Blackstock. I have not read the book yet, but I have followed her since, COVID on Twitter, and she's amazing. So do check out the book. And that being said, one of our peer supporters, Kimberly Guy, often says, if you want to know about the book, ask the author. And I say that because if you want to know about Black and Brown communities, go ask them directly. Go to those communities and ask them. We talk about, participatory research. We talk about co-design. We talk about inclusive research and inclusivity and programs, but yet we're not asking the very people that we want to bring into those programs. And then we wonder why they don't show up. We wonder why when they do show up, they don't stay. So we need to be in those communities, and we need to not just showing up and, forcing our way, but sitting back and really listening and learning. We can learn so much from people who have been in recovery. There's some people who've been in treatment for 27 times, 30 times. And I can tell you, they know what they're talking about. So we need to just sit back and listen. And that's just, basically, that's all I want to say about this.
Since we're still on the pause, I gotta say that Dr. Pullman, you're so right. So often we fight police brutality and saying police have to be socially competent in neighborhoods and know how to serve the people that they are supposed to serve and protect. We need to have that same laser focus on providers that provide healthcare. They need to know the people that they serve. And if we're giving government money to providers and they don't have competent people to serve the people that they are there to help be healthy, then we should redirect that money.
Quick question, Mark. Do we want to go through one more question, or would you like to shift over to question Q&A from our audience? You're on mute.
Yes, you can pose. Go ahead and pose. Yeah, we're good with time.
Okay. So another question for you all. What advice do you have for new professionals just beginning their career, or for experienced professionals wanting to have a greater impact?
Hi, I just want to start with, I normally start with the poem in everything I do, and this is a poem that was developed by my friend and colleague, Imani Harrington, who is a playwright in San Francisco. And she and I co-wrote a book of plays and monologues called Positive Negative Women of Color and HIV and AIDS. And it goes, we need you, our brothers, our sisters, our people. Help us reaffirm ourselves in loving ourselves. Hold us when we can't stand, because soles of shoes have traveled on our backs for so long. We need you, our brothers and our sisters. And I mention that because, as people are coming in this profession, it's really important that one day they realize that we do need them. And for people who are leaders, we need to be able to reach out and grab a hold of their hand. There's the old adage, lift as we climb. But if we are truly lifting as we climb, we are making sure that as we climb that ladder, that we are holding someone's hand and walking those steps with that person. And so that they too can, take their place in leadership. It is important that as leaders, that we also learn to pass the mic, that we also learn to share the stage, that we learn to offer those opportunities so that other people have that, those opportunities to lead. And it also for us, and I know there's another question related to this, because it's exhausting, right? So it's exhausting to be the person that is called all the time for everything. And that's why we must let people know that there are many of us out here that, are either doing this work or want to do this work. So it's really important to share the wealth and share the stage.
Fantastic, Kisha. This is a good time. We can check in with those who've been listening to see if you have any questions or comments that you'd like to pose to the panelists.
I'll go to that. My advice would be collaboration, and uplift those that have the experience. If you could pull together people that are experts in housing, lift them up. If you could pull people that are expert in behavioral health, lift them up and let them do the work. And it's very important starting out that you understand the meaning of nothing for us without us. That means that if you're going to have something and you're doing it, please make sure that you have people that have real life experiences to be a part of whatever you're doing to try to help people in this space.
Thank you. Thank you for sharing that. Collaboration definitely is a force, a powerful force. So we have a question from one of our participants, and it was upvoted. So this is probably our most popular one. As an educator, how do I prevent my students from even thinking about using drugs? We do have a vaping epidemic at present, and I do not want the students to feel the need to try something stronger.
Dare I be the one to say you cannot stop anyone from thinking about drugs? Um, yeah, I don't know how you can stop anyone from thinking about anything. But the question is, how do you empower them, right? And so teachers are often those first responders with our babies. Um, but teachers themselves and educators and people that are responsible for educational systems are also impacted by their own personal bias and thoughts about class and privilege. And so are the messages that you are imparting on our babies while they're in your space empowering, uplifting, or are they rooted in some power and privilege that an educator might not even realize that they have as they're engaging with our babies? And so I'm going to go back to that case of imploring people to examine how they are interacting with people, whether our children or our adults, as they're talking about substance use. What is the messaging that you're bringing, and how else are you empowering them to be their best selves? So is it punitive? Is it, that you're lifting them up? Are you talking about what else is happening in their lives and how that use may or may not be conducive to them meeting their goals? But, you can't stop them from thinking about using drugs, but I can appreciate the question.
I do believe that we could do our best to prevent self-medication. And we see a lot of young people hurting from poverty and living in communities where there's so much drugs and availability. We have to protect them from that. And so I think that making sure that we've heard so much from the doctors here today talk about the social conditions. One, we need to make sure that young people have things in their community that they enjoy and that they're not idle-minded, and that will help. We can't put all the pressure on these young people, expecting them to do right when there's more opportunities for them to do wrong in their communities. And then we look at them as if they knew better.
And Rep. Ford, as you were speaking, I was thinking about Iceland. They went from the highest underage drinking in all of Europe to the lowest. And basically what they did was parents signed that they would monitor their whereabouts, make sure they were not out at midnight on the weekends, and make sure they had lots of activities to do. And they went from the highest to the lowest.
We have another question here. What are your thoughts about including treatment options for African American atheists, a rising number of the population?
What was the question again? I'm sorry.
What are your thoughts about including treatment options for African American atheists, which is a rising number in the population?
I'm not sure where the question is headed, but so please, the person who is asking that question, please feel free to clarify. But I will say that we need to have treatment options and choices for everyone, no matter how you identify. So that's just period.
Next one, are the orgs and structures we are building for our own communities Black and brown, nimble enough to pivot as their drug supply becomes more polluted with analogs and new substances. Any thoughts on that?
Can you
Kisha, could you?
read it one more time? You're
You're
muted.
muted. You're muted.
Are the orgs and structures we are building for our own communities nimble enough to pivot as the drug supply becomes more polluted with analogs and new substances? What are you all seeing?
I don't want to take up too much space here, but so I'm the founder of an organization that is rooted in inner city in New York. And so I think that it completely depends on the organization, right? How many partnerships do you have that would allow you to pivot? If you're seeing an increase in overdoses as a result of a poison drug supply, can you call up somebody from the New York City Department of Health and Mental Hygiene and say, hey, I need additional naloxone kits? Can you call up someone from Oasis and say, hey, I need additional, test strips, right? Can you call? So it really depends on the strength of your partnerships, how nimble you are. Can you call up someone and say, I have someone who wants treatment right now. Can you get them a bed? I have someone that wants residential right now. Can you find them a space? And so what I have found based on the work that I do in the community that I do it is that my nimbleness and my ability to pivot is directly tied to my relationships.
I have a number of questions here. Someone is asking, how do you increase the number of people of color as peer recovery coaches or empowering them to use their recovery experience to benefit others?
A quick answer is, first of all, I just think that more people need to know what peer support is and recovery coaching is. I would say that I didn't grow up knowing about anything related to recovery or peer support or any of that. I didn't learn about that until I went off to graduate school and found out that I needed it myself, right? So, and even within those communities, you're right, it's, mostly white, right? So it's about also making sure that, in these identity specific communities that we're addressing, racism and structural racism, even within those various, systems that we go to for support. But again, just reaching out and making sure that we are hearing the voices and letting people understand, like, what is recovery support? What is peer support? And so that they can see it as an option. Many people would love the opportunity to be able to give back to their communities in such a way. We also need to get rid of some of these impediments around certification and, particularly for people who have histories of, involvement in the carceral system, or people who don't have high school diplomas. So there are so many other ways to address this issue. And then the last one is that your organizations really do need to make sure that we are recruiting and doing outreach with communities of color so that we are hiring recovery coaches and peer supporters who are Black and brown. I mean, there are people out there, but they're often not hired in some of these traditional settings.
Go ahead, Keisha.
I just wanted to mention that there are a lot of questions about whether this recording will be available. Yes, it will be available within a week on the Great Lakes ATTC website. Go
I
ahead.
have a question for the group, and then we will turn it over to Jen and Alyssa. So we all have the same 24 hours in the day, right? It's hard to keep up. We have some people with us today in this webinar who are like behind in their paperwork. I'm 10 years behind in mine, right? And all of you are functioning in a number of roles at the same time, right? Can you just share with us one of your time management secrets to getting so much done?
I would be quick. You know, if it hits your desk, do it right away.
I'm happy to follow up on that one. It's kind of just a variation on the same advice. It's kind of like when you put, if you were to put rocks in a glass, if you save the big ones till last, they're not going to fit. Okay, so you're going to have to put the small ones in first. Another thing that I do on a good day is when my brain is fresh in the morning, it's not time for emails, it's not time for setting up meetings, it's time to do the visionary work and the creative work at that time. Because the older I get, the faster I run out of energy.
Oof, I don't know. I am so bad at this. And so I said on an earlier panel, you know, I take an L on many things, and time management is probably one of them. I am a huge procrastinator, but that doesn't mean that I don't get the work done. I am juggling a lot of balls, but my trick is to try and drop the rubber ones and not the glass ones, because the rubber balls will bounce back. Get to that in a minute. That glass ball is going to shatter. And so I try and prioritize the work in that way, and stop looking at the shiny thing in the corner that keeps coming my way. And so to Dr. Villasant's point, like I love being creative and design. And so any opportunity to do that kind of work, I just want to do it now. But I got stuff that I need to do that, you know, my funders want done right away. So I'm still working on it. I'm a work in progress.
That's what I was going to say. Work in progress, prioritize, delegate, pass the mic, trust that other people can do it. And it will also allow them to grow into their own leadership.
Thank you so much. And once
I'll just finish. I just want to add one more thing to that, that it just so it's not glamorized in any way. You know, it's a total work in process. I haven't been to bed last night and I worked all weekend. Okay, so is that how you want to live your life? Once
And
in a
let me
while,
make
but
sure
not
that,
always.
right. And let me make sure that I'm not the one that's doing it all the time. So you got to have a good team too, but it has to get done right away.
once a week, I encourage those who are joining our webinar today to walk through the world with your head held high. They're going to see with your head held high. They can say, look at her. She thinks she's God's gift to the world. He thinks he's a gift to the world. You know what you are. You've been given the gift of empathy and compassion, and you're using those gifts to make the world a better place. Thank you so much. I turn it over to Kisha, and we turn it over to Jen and Alyssa.
I just wanted to say thank you so much to our panelists and our tech team, Jen, and I guess myself, and also our moderators, Mark and Kisha. You guys were fantastic. I do see that there's, you know, we have so many questions coming in, and I'd be happy to send those questions over to Mark to share with our panelists to try to get those answered for you. Jen and I did put some reminders in the chat. Please make sure you take 2 to 3 minutes to fill out our post-event survey. You should also be redirected. Sometimes Zoom is a little wonky and won't always redirect you. So please make sure you click that survey link in the chat and take the 2 to 3 minutes to fill that out. It'd be greatly appreciated, as it does go back to our funders, so we can continue to provide free trainings to you all. Certificates of attendance will be sent out to all who attended today's webinar in full. And as Kisha said, and Jen responded in the chat, the recording of today's webinar will be posted on the Great Lakes ATTC website within the week. We have so many great upcoming trainings on the Great Lakes ATTC, Great Lakes MHTTC, and Great Lakes PTTC website. So please go and check those out. We'd love to see you guys all on future webinars and trainings that we offer. So I really appreciate, again, to our panelists, thank you so much for being here today. You guys were great. Mark and Kisha, if you guys would like to wrap this up.
Kisha, the last word.
I just can't say enough about this outstanding panel, our Hall of Famers here. Thank you so much for sharing your lived experience, your professional experience, sharing resources, and really inspiring our audience today to, be boots on the ground and not just talk, but, to really not only tackle things from an individual level, but also from a policy level. It's just so much rich advice and experience here. And just thank you so much. I can't say enough for giving your time and sharing your knowledge and your wisdom with our audience today. And thank you everyone for being here. Make sure you
Thank you
take
so
a
much.
Bye all. Thank you.